Here's a situation where an ectopic pregnancy was mistaken for an intrauterine pregnancy. Now, first of all, there was a live embryo here, okay? And on the transabdominal pre-scan, one sees that something is not right with the lower uterine segment. We do not have the normal appearance of a cervix blending into the uterine walls. We have some kind of a thickening. Is there a mass down here? It does not look normal. So we have to be careful now when we scan to figure this out. And what had happened here was the uterus was pushed way to the side, and the ectopic pregnancy was actually sitting in the middle of the pelvis, so that it almost looked like an intrauterine pregnancy. But because we knew that something was not right, we were able to find the uterus and make that call. We don't want to miss a large hemoperitoneum. When you have this pre-scan, you just take the same probe and slide it up under the ribs. This was a patient with a ruptured ectopic and had a very large amount of a hemoperitoneum in the right upper quadrant. We don't change the patient's position. We don't change the probe. We just slide it up under the ribs. If you do transvaginal alone, what you have to do then is change transducers, convert, have the patient move back up on the table. This could shift the fluid back down into the pelvis. Does not make that exam as reliable. Now we have to also now understand the image projection. The transvaginal image is projected 90 degrees counterclockwise on the monitor from what we think that we're seeing anatomically. So let's look at this. Here is the uterus. Here's the probe with the beam, sagittal. This is how it is in the body, but the machine rotates it 90 degrees counterclockwise on the image so that the image is at the top of your picture and comes out. So this is anterior here. This is the anterior part of the uterus. And when it's rotated, this is anterior. So this is anterior, posterior, this is cranial, and this is caudal. Let's do that again. See, caudal is this way, caudal, right here. This is cranial, anterior, posterior. The same thing happens when it goes coronal or cross-section. It still rotates 90 degrees, but in this case, the right side stays on the right and the left side stays on the left. So that when the beam goes into the body, yes, the machine does invert it or rotate it 90 degrees, but it's easier for us to understand the right and the left side. Why is that important? Well, that periodically helps us figure some things out, as in this view here. We have the uterus, and it has an interface here in the middle of the cavity. Now we know that this is anterior and this is posterior. So that means that this fluid level is in a dependent position. And the fact that it is up and down on the picture doesn't bother us now, because we know that something is layering within the uterus, because this is anterior, this is posterior. And here's an adnexal mass, a sagittal image of an adnexal mass. We know this is anterior, we know this is posterior. Our level shows us that dependent material is to the posterior, and even though the level's up and down, we still know that's dependent. That happens, that helps solve us complex cases like this one, where the echogenic material is on the non-dependent portion, which means it's floating. So now, once we make that decision, we know this is anterior, this is posterior, this is floating. Fat floats. We now have a 99% diagnosis of a dermoid. Check beam orientation. We have to be careful which part of the beam is up and which part is down, and that's sometimes hard to do on this transvaginal probe, which has a very small rounded interface, and it's hard to figure out exactly where the beam is. This could be, you could have rotated the probe. Someone could have changed left, right on the machine, pressed the wrong button. So the way we do it is by checking where's the urinary bladder. So why do we even bother with this? Well, first of all, we have to make sure that the image is not reversed. That would help us with the proper uterine position. So if it's an anteverted uterus, if it was reversed, it would look retroverted, and vice versa. Also, when we turn 90 degrees into the transaxial plane, we want to make sure that the right side is correctly registered on the, so we don't mix up the placement of a mass. And it gives us a brief interval of time to just focus a little bit on the bladder, and sometimes we pick up bladder abnormalities. So this is where it becomes important. You have a picture like this, and it looks like the uterus is anteverted. But you see, we could actually just press the left-right button and flip it around. So how do we really know what's the true position of this uterus? Is it an anteverted or a retroverted uterus? Well, the only way to really tell is to check the position of the bladder. On a sagittal scan, transvaginal scan of a uterus, the urinary bladder should be in the left upper corner of the uterus, of the image. If the bladder is on the right upper corner, then you are reversed. So here the bladder is on the left upper corner. This is an anteverted position. Now when you rotate the probe counterclockwise, we usually start, of course, in the sagittal projection. You always keep your thumb on the notch. Every transducer is notched in some way, either has a flat surface or a line or a notch or something that shows you that that's how the beam comes out sagittally, like this. So now you must rotate it counterclockwise. Don't rotate it the other way, clockwise, or you will reverse your right and left sides. Okay, so we've taken the sagittal beam counterclockwise. Now we can scan the pelvis and correctly place the right and left side. We do have to check our technique. We want to check our depth. Always check your gain, which means your TGC and your overall gain, and make sure that the focus is set correctly. First of all, adjust your depth settings. You should start with the maximal depth setting. You want to see as deep into the pelvis as possible. You want to look around and then reset your depth so that you can see 2 to 3 centimeters beyond the margin of an organ. When you start out, you should have your depth open, quickly look around, and then reset it. Fill up the picture with your organ of interest, in this case the uterus, but don't fill it up too much. Don't let the back wall of the uterus come up to the very edge of your image, of your picture, because a mass that's exophytic or very close adjacent to the uterus could be cut off. In this case, this was too much of a change in depth. This was a very shallow depth, and something back here behind the uterus could have been cut off. So this would not be good. We want to step back, make sure we can clear 2 to 3 centimeters beyond the organ. Here was a situation where the depth, here we're focusing on the cervix. The cervix was now made to fill most of the picture, and what's happening here is we're missing the fact that there is a very large mass here behind the cervix. If we had our depth maximal, we would have seen that there was a mass deep in the cul-de-sac. And of course, if we had our transabdominal pre-scan, we would know that something's going on and there's a uterus and there's a mass, and we would have to evaluate everything. So this was going backwards, but if you were going in the proper sequence, transabdominal, then you go to maximal depth, then you change to shallow depth and high detail, you would have covered all bases. Another example, This looks like almost a uterus with some fluid inside of it. But actually, this is just the cervix with a little bit of fluid. The entire corpus is missing here because our depth is too shallow. We want to open our depth, look around, then change our depth and focus on parts of the structure. Another example, an ovary with a physiologic cyst in it. If we would have had maximal depth first, we could have used that cyst to scan deeper into the pelvis and see that there's an ectopic pregnancy back here. So we have to start with maximal depth, then focus closer on an area of interest. We should scan so that we should image that so that there's a 2 to 3 centimeter margin beyond the border of any mass, so that we don't miss exophytic or adjacent masses. Here's a uterus that just about makes it into our field of view, but the whole anterior part here, caudal aspect, are not well imaged. It just so happens that there actually is a mass sticking off the fundus of the uterus, and this was a pedunculated myoma that was pressing onto the bladder and then causing dysuria in this patient. Could have been missed.